welcome to Your Health in Your Hands, Africa's #1 health TV show. My name is Dr. David Ajibade with the Brain and Body Foundation. Thank you for joining us today. Now, as you know, our goal has always been, I think it's about 3 years now, it has always been to provide the average non-medical Nigerian with the knowledge, the understanding, the insights, the health tips, the tools they need to lead a healthy life, whether it's taking control of when maybe they have a chronic condition, they are working with their doctor, what they need to do to be able to ensure maximum benefits from their interaction with their doctor. Or maybe they just want to maintain their health. Or maybe they're trying to recover quickly for an injury or a disease. There are things that you should be doing for yourself that will increase the likelihood of your enjoying a healthy life, not just for you, but also for your family, your kids, whomever, your students, the people you work with. Now, it is not possible for you to lead a healthy life on your own if the environment, and when I say the environment, I'm speaking specifically about the public, what the government, the role the government has to play. It is not possible for you to lead a healthy lifestyle without the cooperation, the active oversight of the government over these key things, these public health matters. And that's why we have had the head of NAFDAC come and talk. We've also had the head of the NCDC come and talk. We've even had the Minister of Health himself come and talk to educate people about what we're doing. Because think about it. If your water is not sanitized, if the water is not healthy, it's going to probably kill a lot of people through disease and infection. We're looking at COVID-19 now. If things aren't under control, if the government doesn't come in and put in strict measures, many people would probably have lost their lives or been very sick and have long-term effects. So it's very important that we also, while we're trying to take control of our health, we also understand and appreciate the role the government has to play in these matters. And that's why we're very, very, very privileged to have on our show today the Executive Secretary of the National Health Insurance Scheme, NHIS, Professor Mohammed Sambo. Professor Mohammed Sambo. We appreciate you making the time to do this, sir. Let's get right into it. I remember when I was in medical school many, many, many years ago, if a patient had a problem, they had a surgery or they had a medical procedure to undergo, if they didn't have the money themselves, they have to call their family and friends and beg and look around, and everybody put money together and they'll pay for their treatment. I remember when I was a house officer in Bomosho, then it was called Baptist Medical Center of Bomosho. Now I think it's called Bowen. But that road, Bomosho Loring Road, used to be the busiest roads, probably than the most dangerous because of a lot of accidents. And people would, over and over again, people come to the emergency room with severe injuries, and they would have to say, we need blood. And of course, we didn't have enough blood in the blood bank, so we would have to have the villagers all donate their blood. And as soon as we say we need blood like this, they're all running away. But bottom line is that people had to fend for themselves when it came to paying for their treatment. How far have we come since then?
Thank you very much. If you look at the basic pillars or the building blocks of the healthcare delivery system, there are about 6 of them. One of them is leadership and governance. The other one is human resource in healthcare. The third one is service delivery. The fourth one is the healthcare financing. The fifth one is supply of commodities and drugs. Then the last one, which is not the least, is the healthcare financing. So understanding these building blocks of the healthcare delivery system will enable people and groups to understand how the healthcare system works. Looking at the 6 building blocks, it is therefore important to recognize the role of healthcare financing in the healthcare delivery system. And that is why healthcare financing has become a major public health concern now. If you take Nigeria as a test case, you realize that the population of Nigeria is on the increase, and it's not is not commensurate with the rate at which resources of the country, especially financial resources, is increasing. So there is a mismatch between the population growth and the resources. So now, because of the inability of individual and family to muster resources for the healthcare delivery system, they have to cope with that problem. If somebody is ill, he will have to look for money. If he has that money, he will go and pay for the services. If he doesn't have the money, he will go and look for a brother or sister who can help him to be able to put the medical bills. Then if nobody in the family, he might go and sell his assets just in order to have healthcare delivery services. And a situation whereby somebody who is agrarian, who is living in a rural community, will not afford to pay for the healthcare services, and nobody in the family or in the community can assist him, he will have to go into a situation of selling his precious asset, like a farmland. And when he sells his farmland this year, next year he will not have any farm to farm and get a means of livelihood. So there is healthcare delivery process of seeking for healthcare has a capacity to push people into a vicious cycle of disease and poverty and disease and ill health. And in fact, in some community, it has been the situation is so bad when you go to a place like rural China, where people will have to even sell their daughters for them to be able to settle medical bills. So given this background, then what are the various options that are available for mobilizing funds for healthcare delivery services? The one that is very popular is the general tax revenue, whereby government will be.
Sorry, Prof. We're going to have to take a short break at this moment to do that. But I do want you to hold that thoughts, because we're getting into the real meat of this matter now. How you're going to generate the money so that this problem of people selling their organs or precious commodities to stay alive does not have to come to pass. So just hold that thought, and folks, we will be right back after this short break. Welcome back, folks. We are here with Professor Mohammed Sambo, who is the Executive Secretary of the NHIS. We are talking about how his agency is seeking to offset and help people be able to have proper insurance for their medical bills and medical challenges. Go ahead, Prof. We're talking about raising funds for this.
Yeah, one of the major ways of raising funds for healthcare delivery services is general tax revenue. General tax revenue is a mechanism whereby government conduct a budget year in, year out, and out of the budget, proportion of it will go into the healthcare delivery services. Number two, healthcare fund can be obtained from donors, which we would call donor financing, whereby international development partners will come and put their money in the healthcare delivery system. Number three, health resources can be generated from health insurance. And that's exactly what my agency does. And when you take the health insurance system, it has been adjudged as one of the most progressive healthcare financing arrangement, because it has what is called a capacity to engender proportionate equity. It has a capacity to engender progressive equity. Progressive equity is, to what extent do we contribute for the healthcare, whereby we contribute to healthcare based on our capacity to pay, and we earn the same package of care.
I see.
Let me expatiate it. For example, in health insurance, there is what is called pooling of resources and pooling of risk. By pooling of resources, somebody as a director will pay proportionate amount of his salary into the health insurance pool. and a messenger will also pay proportionate amount of his salary. For example, if a director's salary is 100,000, he will pay, say, 5% of 100%. How much would that be? 5,000 into the insurance fund. Then a messenger who earns 10,000 naira, what is his proportion of 5%? Is 500 naira. So you see, the messenger pays less, and the director pays more. And if you look at the epidemiology and the distribution of diseases in human population, you see that the poor people are more prone to healthcare challenges. So that poor person, because you have pulled the risk, you have also pulled the resources in one basket. The money will now be taken and pay for the healthcare for the poor. So it has this progressive equity, despite the fact that you pay less, but you benefit from the funding the more. That is health insurance. That's appealing feature. That's appealing feature of health.
If I may jump in here, Prof. So you've just described it very well. Now, the listeners and our viewers might be wondering, okay, how much and what proportion of people, first of all, have access to what you've just described? Is this just for governments, big government and businesses, or is the average, like you mentioned, the agrarian person, does they have access to it? Who has access to what you've just described now?
This is a very good question. There is what is called Universal Health Declaration, Universal Health, US Universal Health Coverage. This is a target of a global community under Sustainable Development Goals agenda, whereby everybody, the international community has agreed that they are in the spirit of social justice. Everybody should have access to basic healthcare services. And the best way to guarantee attainment of universal health coverage is when you have a very robust health insurance arrangement. And in that health insurance arrangement, there is stratification. Stratification in the sense that you now take people that are gainfully employed, either in a formal arrangement or in a private sector arrangement, and they have a consistent salary flow. And you take proportion of their earnings, just as I described earlier, and you put it into the basket. Then you have people that are self-employed, who are not working for anybody, but they are working for themselves, and they are earning good amount of money, self-employed. They have capacity to pay into that health insurance fund. Then you have the third category of people who cannot afford at all to pay for the healthcare delivery services because of the level of poverty. That is to say, these people are living below poverty line. They are trying to grapple on how to even get 3 square meals. Those people are categorized as vulnerable, and those people cannot be able to pay for their healthcare services. So government and other arrangements can come to support in paying the fees for health insurance for those vulnerable in the spirit of attainment of universal health coverage. So the health insurance scheme is supposed to be for everybody. For those who have capacity to pay, and for those, then they pay them for themselves. For those who have no capacity to pay, then the country should make a subsidy arrangement and subsidize for their payment. And it is a pro-poor program whereby poor will benefit. Instead of doing a budget and the budget is taken to where you will not know, you can now aggregate that money and say that I am going to pay for health insurance for the people who are poor, and they can access healthcare delivery services, basic healthcare delivery services anywhere, anytime.
Do we have any number in terms of percentage-wise of how many people have percentage-wise, how many people currently have access to this scheme?
Yeah, in giving absolute number, you have to consider the nature of political arrangement of Nigeria, because health is said to be in concurrent legislative list, whereby federal government has its own arrangement, and state have their own arrangement. Ideally, at the beginning of the national health insurance system, everybody should have come into the health insurance system and bring and ensure that the employees of the federal government, the employees of the state government, and the employees of the local government come into one pool. Then you now bring the private sector. You now then bring the self-employed. Then you now bring the vulnerables. So, but because of the decentralized nature of our political system, whereby states have their own autonomy, you now have a situation whereby we have the national health insurance scheme at the center, and you have state health insurance agencies at the subnational level. So for you to get a real accurate data, you need to aggregate the totality of the efforts that is being done at the national level, as well as the ones that are being at subnational level to come up with a figure. But however, I want to tell you that the coverage of health with respect to the health insurance is still very low because the state are just coming into it. Even the state, they did not come on their own volition, but they have to rely on the subsidy program, which is a federal government program, that we call Basic Healthcare Provision Fund. It is a proportion of consolidated revenue fund of the federal government that is dedicated to the vulnerables, which I have explained, to ensure that vulnerables are enrolled and covered. But the mechanism of action of that program is that the money comes from the federal government. It is dedicated to the state. It is pushed to the state government, the state health insurance agencies. They do the enrollment of the vulnerable, and they pay for their services. So most of the states in Nigeria did not start the implementation of the real formal sector social health insurance program, but this vulnerable program. But the kind of advocacy we are doing to them, you cannot run health insurance program with only vulnerable program. You need to have a very credible formal sector program, and the vulnerable program will be a complementation.
Fantastic. Yeah. So that's one of the challenges. So the data collection. I think in the last segment, we want to talk about some of the other challenges you're seeing and how hopefully we're going to overcome them in the next years, in the coming years. So at this point, we're going to have to take a quick break, folks, and don't go away. We'll be right back with the prof. All right, welcome back, folks. I'm here with Professor Mohammed Sambo, the Executive Secretary of the National Health Insurance Scheme. We're talking about the challenges of insuring Nigerians, and we're going to talk about the successes as well. Go ahead, Prof. Let's talk about those challenges.
Yeah, last 1.5 years when we came to the National Insurance Scheme, the challenges were so enormous that Mr. President had to set up a committee to investigate what were the causes of the myriad of challenges that bedeviled the organization. And as a result of that, the board of the Governing Council was dissolved and the appointment of the Chief Executive Officer was terminated. Then we were appointed to come and undertake reform. And when we came, we analyzed what are the challenges, and we compared the challenges we have analyzed with the one that the Presidential Independent Fact-Finding Committee has done. And they categorize problems into different domains. There are problems that has to do with the law establishing the National Health Insurance Scheme, which is not mandatory. And for you to have work towards universal health coverage, you need to have a mandatory law. And the government has asked us to do everything possible to ensure that the law is amended to be mandatory. There are numerous issues that has to do with governance and human resource. We also had so many operational issues that has to do with the enrollees, with the slow pace of the penetration of the health insurance, because there were no credible programs that will bring informal sector, which is larger than the formal sector, into the system. So having aggregated all those challenges, we now unveil what we call a 3-point rebranding agenda in order to be able to confront all those challenges frontally. And this rebranding agenda is anchored on 3 pillars. Number 1, restoring value system to make the National Health Insurance Scheme credible and result-oriented organization. Number 2, engendering transparency and accountability in the operations of the health insurance. And number 3, to accelerate the drive toward attainment of universal health coverage. We swung into action. We deconstructed those 3 pillars into elements. And part of the elements is that in number 1, how do we make NHIS to be a stable organization so that all the challenges that has confronted the organization will disappear into a thin air? And we have worked assiduously in collaboration with some organizational consultants, and the organization is now adjusted to be one of the most stable organizations in Nigeria, which was hitherto not. Then with the restoration of peace and tranquility within the organization, we began to reach out to the stakeholders to restore the confidence of stakeholders, and we began to put a mechanism in place to ensure that NHIS work with evidence. We also unveil different strategy to ensure penetration of information education and communication to our team release. We also unveil so many far-reaching programs like the 10-year strategic plan. For the 20 years of existence of the National Health Insurance Scheme, it had no strategic plan. So for the first time, we developed a 10-year strategic plan, and we are following the implementation of this plan systematically. Number 2, we have created a program that will expand access to the social health insurance in Nigeria. One of them is implementation of group, individual, family social health insurance program, so that as an individual, you can come into the NHIS, as a family, you can come, as a group or association, you can come. In fact, it is our vision that through this gift program, many philanthropists will come and support people that are indigent and vulnerable to pay for their premium. International donor agencies can come and identify some group of people, like say an international agency that is working with a group of people with disability can come and pay premium for them and benefit from the benefit package of health of NHIS. This program will also avail even our kith and kin in diaspora to key into the health insurance program in Nigeria and develop capacity to pay for their brothers and sisters that are still onshore, so that they will also have access to the healthcare delivery system. So this gift ship program has been launched by the Honorable Minister of Health, and people are getting to embrace it en masse. So with this program, we have created a slogan that nobody is leaving no one behind in the healthcare delivery, in the health insurance. Then we have also made a gigantic effort to ensure that we automate the entire business process of the National Health Insurance Scheme. When we came in, the system was operating manually, surprisingly, in the 21st century. But we swung into action to develop a credible infrastructure, ICT infrastructure that is of international standard. It is our hope that the infrastructure that we develop will have an opportunity to do what we call interoperability, a handshake with all the stakeholders, the health maintenance organizations, the healthcare providers, the state health insurance agencies. So all the issue that has to do with data aggregation, that has to do with business process in terms of accountability and transparency, in terms of payment of modules, in terms of accreditation of healthcare facilities, in terms of grievances redress and complaints and redress, all can be done within the framework of the digital transformation we have put in place.
Wow. That's extensive, Prof. That's fantastic. I think the key things, I mean, I have to commend you on this whole grand plan to do this, because one of the key things I hear about this is the communication, getting the word out as much as possible so people can know about it. And then two is the data, the being able to integrate and collect this data and make sense out of it. So I think that's absolutely huge. I know that what you're doing is so much more than that, but we definitely wish you the very, very best in achieving these long-term goals. I know you will not be here to see, I mean, you will not be in that position to see the fruit of your labor, but I know you'll be very, very happy about it. So we have to end at this point, but if you want, is there any final word that you want to share with us, with our viewers before you leave, sir?
Okay. My final word is that hitherto people have lost confidence in the National Health Insurance Scheme. But with the massive reform that is going on, I think people should closely look at what is going on in the National Health Insurance Scheme and create some level of confidence and join us. And they will never regret joining the health insurance. In fact, yesterday, I read a paper that the retirees of former National Prison Service Correctional Center, they want to get out of the pension. They are calling for president to take them out of the pension scheme and bring them into the National Health Insurance Scheme. This has gladdened my heart, and this has a clear testimony that people are looking at what we are doing and they are ready to do business with us. Thank you very much.
Fantastic, fantastic. Congratulations, Prof. That shows that your work is going well. So, folks, we're going to have to end it here. We definitely are going to have Prof back to talk to more to us about insurance. But at this point, our time is up. Thank you for joining us, Prof. And thank you, viewers, for joining us on this program. We shall see you again next week. God bless. Take care.